Bonjour, good morning, sabah al-khair. I think many of you have not seen me the first day, so allow me to state briefly why I'm here. I'm actually a political journalist and a commentator. I'm not a doctor or a researcher or even a member of a breast cancer society. My interest in this is I lost my mom when I was 9 years old to cancer, and since then I lost many friends and members of my family. Cancer actually ravaged my life. It's not easy to have somebody that you love so much get sick. It's very, very difficult to see them suffer. So cancer is not only associated with this horrible silent disease, but it's actually associated with suffering. And I really am very happy to be with you here, to see how much you are working hard to discover how we can help people, hopefully one day eliminate this disease, but in the meantime, help people get better as soon as we can. Well, I want to welcome you, of course, for this plenary session. I'm seriously looking forward for it with a lot of anticipation and happiness because the participants, one is a very close friend of mine, Her Royal Highness Princess Rima bint Bandar Al Saud, and Dr. Lange, who's promising to give us an amazing presentation. She's been working in the field for such a long time. Dr. Lange will speak, and I'm going to have a conversation with Princess Rima. But first, allow me to introduce to you somebody you know very, very well and deserves a huge congratulations today, is Her Royal Highness Princess Reema from Jordan, who has won the presidency for 2018. You have kindly elected her. So can we have a big, huge clap for Princess Dina? Congratulations. And also allow me to invite her to say a few words, and then we will go on with our session, which I've been telling you about, and then I can also say a few words about the speaker and the Princess Reema as well. Thank you.
Good morning, everybody. Your Royal Highness, Princess Reema, Excellencies, and most importantly, dear friends and fighters for cancer control. And thank you very much, our wonderful, famous journalist, Bari'a, for the introduction. Many of you will know I am a fierce advocate against the tobacco industry, an industry that kills 6 million people every year. For years, I have been campaigning in Jordan and globally to reduce tobacco use and hold countries to account to implement the WHO FCTC, the UN Treaty on Tobacco Control. When we last met for the World Cancer Congress halfway around the world in Melbourne, Australia, I was told that I am to meet a Dr. Bronwyn King to learn about a new initiative, tobacco-free portfolios. I expected yet another positive initiative as one of the many against the tobacco industry. And of course, I was more than ready to help. And of course, I was expecting, who is this woman coming with this new initiative that has a big fancy name, tobacco-free portfolios? And lo and behold, I find this beautiful blonde bombshell coming my way. And I said, okay, now we have something here. Then after speaking with Dr. Bronwyn, I realized that she is onto something big. And I mean big. Bronwyn King, it seems, has outed perhaps one of the biggest private, sly, and secretive conversations to date, something akin to Watergate. It was clear to me that Bronwyn has uncovered our own portfolio gate. Like many others, I had not considered that our money, the community's money, the money placed in pension funds, was being invested in tobacco companies. I had not realized that tobacco control advocates like me and you were unwittingly investing in the very companies that we are campaigning against. I did not realize that also most governments were investing in the tobacco industry through their sovereign wealth funds, all in direct contrast to the great efforts to implement and enforce the FCTC. How outrageous is that? In simple terms, whilst we are all trying to stop and suffocate the tobacco industry, every day of every month of every year, we are also unknowingly giving a steady lifeline by financing it. So when Bronwyn asked me to chair the Global Task Force for Tobacco-Free Portfolios, I jumped at the chance. I believe that everyone should know exactly what he or she is investing in. And if they are investing in tobacco companies that kill 6 million souls a year, they should be able to say no. We should all say no, exactly as Bronwyn has done. First with her own pension fund, and then with another, and another, and another. The conversation has now extended to include banks, insurers, and all aspects of the finance sector. In just 4 years, starting in 2012, with one brave, ethical, and determined individual, in the person of Dr. Bronwyn King, 35 large Australian pension funds have divested from the tobacco industry. 35 large Australian pension funds. Funds with combined total assets of more than $500 billion, Australian dollars. In May of this year, we welcomed also the announcement by AXA of a 1.6 billion euros tobacco divestment. Global momentum is building. All great ideas start with one person. However, they become magnificent deeds with the support of others. The tobacco-free portfolios now need to scale up its operations all over the world. And for that, they need the funds to set up a formidable team. If there were one project that gives a proven, low-cost, efficient high rate of investment, it would be tobacco-free portfolios. One-person team versus $500 billion plus divestment. So your support is now crucial and critical if we are going to see investing in tobacco stock as a thing of the past, something future generations, including my children and your children, will consider unimaginable. So you're addressing the financial support and the financial power of the tobacco industry has been the missing piece in tobacco control. Effective tobacco control requires us to work together across sectors and across countries, governments, public health experts, doctors, and the health sector, non-government organizations, and importantly, the finance community must now come together to change our world. We have never been so connected as an international community. Tobacco-free portfolios is one initiative that we should all be investing in, as we would be investing in a very ethical, attractive, high-return portfolio that not only divests from blood on its hands, but rather invests instead in the most valuable of assets, millions and millions of lives saved. But before I hand over the microphone, always a difficult task for me, I would like to introduce the Tobacco-Free Portfolios video. Thank you very much.
Thank you so much, Your Royal Highness Princess Dina. This has been really eye-opening for us all, I hope. And of course, Princess Dina comes from a region where smoking is high on the agenda of young girls and boys and men. And you know, people in that area, if they're having troubles, oh, I'll smoke, it'll make me feel better. If they're happy, I'll smoke. It's part of the celebrations. You know, smoking cannot be part of any celebrations or any solving of problems. Tobacco is simply a disease and it kills. Thank you. Let me now come to something equally serious, equally informative, and I would like to invite Dr. Analinga to come to the stage here. We want to discuss with the coming panel really interesting things and highlight women who are deep in poverty. What is the effect on their health? Poverty and health is really important. Also, you know, we know that breast cancer is the fastest rising cancer in poor regions of the world, especially in Asia. Also, we'd like to highlight in rural cervical, in the rural areas, still cervical cancer is the #1 killer. While here in Europe, we know that cervical cancer doesn't kill anymore because there is early detection, and also there is a way where you can get proper treatment. Also, vaccination is important, as we know, in some areas of the world, in many areas of the world, especially in the poor areas, people don't even know about this vaccination. So please, Dr. Lange. Dr. Lange, as we all know, is more famous than for me to introduce her, really. She has joined the Harvard School of Public Health in July 2010. She's a professor of the practice of public health and also director of the Women's Health and Health Initiative. And also, Dr. Lange is, together with other physicians, she has with collaboration with them, she has, with the experts, sorry about this, they created and published a comprehensive report on women's health around the world. And I hope you can all have a very good look at it. She also specializes in pediatrics and other issues. But her research is huge, is vast, and very, very effective. Thank you. Please.
Bonjour, good morning, buenos días a todos. Your Royal Highnesses, colleagues, and friends, special thanks to Arya for her very kind introduction, and my very special thanks to Dr. Sanchi Aranda for inviting me to share with you some thoughts and some evidence about women and health, which is the topic of a Lancet report, as Arya said, that we published last year, that it covers very comprehensively issues that relate to women and health, as I will explain in a minute. And it's also the focus of my program at the Harvard Chan School of Public Health. While I will talk about women and health globally, inevitably I will direct more comments towards women in low and middle income countries. The most vulnerable women, because they are the targets of our program and also the population group that I've been trying to help throughout my career. So during the next 25 to 30 minutes, I want to cover the following points. I will explain what Women and Health is about. I will give you some highlights about women's burden of disease currently. I will also make some points about the unique challenges that women's health faces. I will also tell you a little bit about women's contributions to healthcare, and I will end up with some key recommendations for the advancement of the non-communicable disease and cancer agenda that I think will be relevant for you working on this very, very high priority nowadays. So, what is women and health? Women and health is a novel concept that refers to the multifaceted pathways through which women and health connect. It goes beyond the more traditional focus on women's health to look at also the contributions that women make to healthcare. It also highlights the potential for synergy between those two roles that women play, where bearers of health problems and healthcare providers themselves. As I said before, this concept and the evidence that supports it was extensively described in the Lancet report that I would be happy to share a link with you of if you are interested in learning more about it. So this is the conceptual framework that we propose in the report. What we say in the report is that in the context of dramatic economic, social, environmental, and demographic transitions, women's health is going through a very, very intense epidemiological transition that can be characterized as an overlap between the unfinished agenda of sexual and reproductive health, malnutrition and infectious diseases, and a true tsunami of non-communicable diseases and cancers. And now government, civil society, the society in general have to deal with this dual burden of disease, which is not easy, particularly in low-resource settings. Health systems, therefore, very often do not provide effective responses to women's health needs, although health systems rely heavily on women. As I will explain in a few minutes, women are a majority in the formal health workforce and also as providers of health care in the households and communities. But girls' and women's health and women's experiences as caregivers are affected by the same social determinants and contextual factors that you can see on the slide: gender equality or inequality, violation to human rights, including the right to health care, social justice or injustice in many places, human development and culture that too often limits women's capacity to fulfill their potential. A central principle of the women and health approach is that because of this persistent social and gender inequality, violations to human rights, and the cultural backgrounds that perpetuate injustice and limit women's human development, women are at increased risk of ill health and have a low status in the health system and in society. Next, I will discuss with you the first pillar of women and health, women's health, represented in the blue circle. We consider women's health through a life course approach. We look at women's health as a continuum and recognize that women and girls have special needs throughout their life course, determined both by biology and social determinants, in particular gender, rights, and socioeconomic status. We emphasize that health and well-being in each stage influence health and well-being at subsequent stages. And in the case of some conditions, it also influences the health and well-being of the next generation. For example, good nutrition, early child development, interventions, a healthy adolescence, especially as it relates to tobacco use, alcohol consumption, dietary habits, physical activity, and education, of course, will contribute to good health during the rest of a woman's life. The effects of access to health care or lack of access thereof also accumulate over a lifespan. The HPV vaccine, for example, administered in late childhood or early puberty, will prevent cervical cancer in adulthood. In the case of women, most of the focus so far has been on sexual, reproductive, and maternal health conditions, while NCDs, which are a growing component of women's burden of disease, are often neglected. This siloed approach that focuses on one stage over the other or one condition over the other is not helping women to achieve good health because, as I said before, women's health is going through a very complex epidemiologic transition. Let me use maternal health as an example. This graph seems complicated. It's not that complicated, and you don't need to look at it into detail. But it provides the main causes of maternal mortality, which are the deaths that happen during pregnancy or during delivery and the immediate postpartum period. The two green layers at the top represent conditions that are not obstetric conditions. These are non-communicable and chronic conditions that affect women's health during the reproduction period. Unfortunately, however, the attention of the global and national communities focuses on maternal health or, in some cases, non-communicable diseases, as if they were not linked. Whoever provides care to women during pregnancy should pay very, very close attention to these non-communicable diseases that until not so long ago weren't that prevalent as they are nowadays, for a number of reasons. First, because they are an important cause of maternal morbidity and mortality. Second, because maternal health care or the contact that women have with the health system while they are pregnant and after pregnancy provides a unique opportunity for the health system to engage women in their long-term care, and also to educate them and to inform them about the prevention of non-communicable diseases, early signs of non-communicable diseases, the resources that are available in their communities to deal with chronic problems, and therefore establish a longer-term relationship with women for and when they need it. This last point is particularly important because some of the conditions that affect women during pregnancy increase the odds of them becoming chronic a few years later. Let me use this as an example. A woman with gestational diabetes mellitus has an increased risk of type 2 diabetes of 60% in the 5 years following the delivery. Peripartum depression, which is now gaining a lot of attention, luckily, becomes chronic in 30 to 50% of women who are affected by it during pregnancy or after delivery. And in fact, it also relates with mental health conditions earlier in life during adolescence. Women with hypertension have an increased risk of during pregnancy, have an increased risk of chronic hypertension, especially women who had recurrent preeclampsia and premature deliveries. In fact, NCDs dominate women's global burden of disease, as I will show in this graph. Please, again, don't get overwhelmed by the graph. Just look at the top causes of mortality. This graph compares the main causes of women's deaths in 1990 vis-a-vis 2015. These are very recently published data that show that in the last 25 years, NCDs that were already very, very prominent in 1990 became even more prominent. Now cardiovascular disease, cancer, diabetes, and chronic respiratory diseases are among the top 5 causes of death. If we look at the different stages of women's lives, as this graph shows, NCDs, which are the orange part of the bars, are the cause of the largest numbers of death of women at all ages, except for the youngest ones. Among middle-aged and older women, NCDs become even more important as causes of death, occupying the top 4 places. As these very brief data that I shared with you show, NCDs affect women's health throughout the life cycle. This is, however, a notion that has not been fully recognized and embraced by policymakers, donors, providers, and women themselves in lower resource settings, where health professionals and the public continue to think that the health problems that women face are related only to sexual and reproductive risks. While this is certainly an unfinished agenda, It is also a misperception that needs to be changed in order to generate the sense of urgency that is required to push the NCD agenda forward and to design and implement effective interventions that really deal with the comprehensive women's health agenda. The importance of NCDs in low and middle-income countries vis-à-vis affluent ones can be confirmed by looking at age-standardized death rates. This graph shows that more women per 1,000 die of NCDs in Africa, including Ethiopia, Uganda, and Nigeria, the last 3 columns on your right, than in high-income countries. In fact, that is not surprising because risk factors are increasing among women everywhere, including low and middle-income countries. For example, obesity, which is associated with low socioeconomic status and is a critical risk factor for a wide range of NCDs, is increasingly common in sub-Saharan Africa, where it affects more women, in purple, than men. Obesity is also on the rise in Asia and Latin America. In fact, it's on the rise everywhere. Urbanization and changes in dietary patterns comprise of energy-dense food and physical inactivity, oftentimes a product of the social and cultural context women live in, are all linked to obesity. Let me get some water. Tobacco use, we were just talking about that in a very, very compelling way, is also growing among girls and women, as girls and women are probably the main target of tobacco companies, especially in countries with emerging economies. Marketing campaigns are targeting women by associating smoking with independence, sophistication, sexuality. Other prominent themes used in advertising, including weight loss and stress relief. As a result of these pressures and cultural changes, the number of female smokers and deaths due to conditions linked to tobacco use are on the rise. Next, I will discuss some unique challenges that affect efforts to improve women's health in different spheres. Let me start with access and quality of care. Women are especially susceptible to economic, sociocultural, and geographical barriers. Women often prioritize the well-being of their family over attention to or expenditure on their own health. Many women are unable to make decisions about their health care without the guidance and approval of their husbands or other members of the family. Women tend to be less mobile than men, as they are likely to remain in the home to adhere to their domestic roles and may be unable to afford public transportation. Some women are not even able to travel alone. Women are also more likely to experience stigma and discrimination over NCDs due to their etiology. For instance, the knowledge that now is quite common that cervical cancer is the result of a sexually transmitted infection, or their consequences, for instance, mastectomy that may follow breast cancer. Therefore, women with NCDs can be discriminated against in terms of their ability to get married and are more likely to be divorced, separated, and abandoned by their spouses. A third point I want to make is that warning signs and symptoms of certain NCDs, like cardiovascular disease, are different for women compared to men. Women are more likely to have atypical symptoms during a heart attack, including shortness of breath, back pain, indigestion, and no chest discomfort at all. This results in misdiagnosis, later diagnosis, and a less aggressive treatment for women than for men. Long-held misconceptions that cardiovascular disease is a men's health problem definitely affect these misdiagnosis and lateness in diagnosis and treatment. In summary, clinical manifestations vary by sex and care varies by gender. The challenges faced by women also include the research sphere or the academic sphere. Female subjects, women are less likely to be included in research studies, as bench and clinical research subjects are overwhelmingly male. And that is because researchers very often worry that women fluctuating hormone levels will affect the design of their study, or they are concerned that including females will require researchers to double their sample size. What happens as a consequence of that is that all findings that are based on studies that only enrolled men or male subjects, sometimes it's animals, not humans, the findings are applied then to female subjects or women without having paid enough attention to the differences, biological and social, that exist between men and women. Basically, sex discrimination in research limits the generalizability of research findings and their applicability to women, sometimes with dramatic effects. There are some examples that I would be happy to share with you if we get into this theme during the discussion section. I already mentioned that in spite of the global burden of disease data, in low and middle income countries, most governments and also donors, global donors, still focus on pre-transitional health problems, and it has been difficult to generate enough momentum or traction to get the resources and attention we need to effectively fight NCDs. Due to these and other factors, health systems in lower income countries in particular do not meet women's needs, in spite of, as I was saying before, the fact that women are a majority in the healthcare workforce and play critical roles in healthcare at the household and at the community level. That's the second pillar of the women and health concept. In most societies, caregiving is seen as a normal part of a woman's life, as a normal part of her domestic roles. Girls and women provide care to children, acutely and chronically family members, and people who are disabled or dying. The epidemiologic and demographic transition, that means that there are more elderly people in the family and also more chronic diseases, are increasing demand for long-term home care by women. Domestic healthcare providers, however, are not trained, are not linked to the health system, are not recognized, and with very few exceptions, are not remunerated. Their opportunities for education and generation of income are non-existent or very limited or interrupted when girls and women have to stay home and care for a family member. Their work represents an invisible subsidy to the health system and to societies. Community health workers are overwhelmingly female, and their contributions are absolutely essential for the health and well-being of the entire community, but in particular for women and children, and especially those with no easy access to healthcare institutions. This is a picture of midwives in Guatemala, a country I worked extensively in, where most midwives are women, but you can see the same thing in Pakistan with a very successful lady health workers program, or the health extension workers in Ethiopia and many other countries. Community health workers do not always get a salary or a stipend, and when they do, the amounts are small, inconsistent, and insufficient. In addition, community health workers have low status within the health system and are poorly connected to higher levels for referrals, supplies and drugs, training, and supervision. Women are also a majority in the formal healthcare workforce. Nurses, most of them women, comprise 80% of health workers. But female nurses earn less than male nurses, even in the same discipline, and are often not allowed to practice up to their full capacity. Furthermore, nurses, despite being the dominant health workers in developed and developing countries alike, are often not represented in decision-making bodies or health institutions and governments, and lack the power to make their voices heard. The proportion of women physicians is also increasing everywhere. This graph shows trends in high-income countries, but the tendency is the same in middle-income countries and in some low-income countries as well. These numbers, however, do not necessarily translate into more influence of women doctors in the health system. Due to a lack of policies that allow women to integrate their professional and domestic roles and respond to social expectations, female physicians are less likely than men to practice medicine once trained, to complete medical residencies, work full-time, or take leadership positions in clinical services. Aware of the importance of women's contributions to healthcare and the barriers they face to fulfill their potential, the Lancet Commission on Women and Health decided to generate evidence about the monetary value of women's contributions to healthcare, hoping that this data would become a powerful advocacy tool for policies and programs that would support and enable women everywhere. This project that we called Global Valuing the Invaluable project was led by Commissioner Felicia Knoll and implemented by her and other health economists, and it represents one of the most original contributions of the Lancet report. Based on time use surveys, employment surveys, plus minimum wages data as reported by the International Labour Organization from 31 countries, we estimated the monetary value of women's paid, under, and unpaid contributions for healthcare in the health sector, in the communities, and in the household. An immediate finding was that these contributions, even when paid, are often undervalued and under-remunerated, reflecting discrimination against women. The numbers Felicia and colleagues came up with are staggering. $3.1 trillion is the size of the invisible subsidy women give to society and the health sector, representing both paid and unpaid work. Putting it in context, please look at the purple box. That amount exceeds the total US plus UK health budget. It's almost 3 times the size of the Mexican economy, 20% of the US economy. And each and every woman contributes, each of us women here, contributes $1,200 to health care annually. Our study, however, did not focus on another important way through which women influence health, their academic contributions, and the special challenges women face in that environment. It has been documented that women are especially interested in women's health and gender disparities as fields of study, but their underrepresentation in academia stalls this agenda. In a system characterized by very, very high competition, women often face the challenges resulting from, again, the lack of supportive policies to allow them to integrate their reproductive and domestic roles with their professional ones. Consequently, they have fewer opportunities for publication, especially as first authors, and the grants they get are smaller than grants that their male counterparts get for similar studies. The reasons for that are unknown, but it has been well documented, this as a fact, in the US and in the UK. In a system based on publications and grants, this inevitably results in fewer women in leadership positions, who could be role models for junior researchers and advance a research and teaching agenda focused on women's health. This is a vicious cycle that needs to be transformed into a virtuous one. The recommendations we make in the Women and Health Lancet report focus on the whole construct, women's health, women's roles as caregivers, and the interplay between these 2 dimensions. Before briefly discussing with you some recommendations, I would like to say a few words about that interplay, the overlap between the 2 circles, using breast cancer to illustrate it.
We're running out of time. If you could kindly wrap up.
To go faster?
Yes, we are running out of time.
I'm almost done.
Good.
I don't need to tell you that breast cancer is the most commonly diagnosed cancer in women worldwide and also the leading cause of death by cancer in low and middle income countries. But women are not only patients, they are not only the bearers of breast cancer, they are also key to the fight against breast cancer. But when women are undervalued, under-recognized, and not enabled to take care of their own health and the health of their female relatives and other members of the community, both they suffer as breast cancer patients and as well as providers of healthcare as well. We think that valued, informed, and empowered women will have a better chance to become better caregivers and advocates. So very briefly, we organize our recommendations in 4 groups. Value women, we think that all women should have access to universal health care for their comprehensive health needs, and that the policies that I was talking about that would allow them to better integrate their domestic and professional roles would be key to advance a women and health agenda. Compensate women, estimating the value of women's unpaid and underpaid contributions to healthcare, and most importantly, recompense their invisible subsidy would be very important. And studies replicated at the national level as the one we did at the global level would be very critical. And of course, it would be very important to bridge the gender gap in compensation. Count women. This is particularly important. Let me just talk about the second bullet as I run out of time. For conditions that women share with men, like non-communicable diseases, we need to advocate for sex disaggregated statistics. Without them, we will never know in what way those NCDs particularly affect women, and we won't be able to take appropriate action. And of course, mandate that research studies enroll women, and the publications are also that findings are also disaggregated by sex. Finally, we need to develop an independent accountability framework and indicators for women and health. Change is possible. Let me say 2 words about why I'm optimistic. NIH, now National Institute of Health in the US, requires researchers to account for the possible role of sex as a biological variable in both animal and human studies, and the European Commission is doing something similar. Hopefully, journals will start soon applying a consistent policy to require that findings also take into consideration sex and gender. The case of maternal mortality, my field, shows that change can be possible. This graph shows how maternal mortality ratios have declined in the last 15 years, and that hasn't been an easy task. There is no magic bullet for maternal mortality. Health systems needed to be strengthened, social determinants addressed, but we were able to achieve a significant reduction. So when there is political will, commitment, and a cohesive community, change is possible. There are some inspiring examples from some very low resource settings, like Haiti and Rwanda in this case, that show how innovation can play an important role in the fight against cancer. Finally, let me finish with a quote from a female doctor, president of Chile twice, and a member of the Lancet Commission on Women and Health, Michelle Bachelet, who said, "Women's strength, women's industry, women's wisdom are humankind's greatest untapped resource." Thank you.
Thank you very much, Dr. Anna Lingi. I mean, I would have liked to go on listening to more and more facts. Fascinating presentation. Really, unfortunately, we are here bound by time. And I'm sure you know that a sick woman is a sick nation, is a sick world. We women, I hate to say, would like to rule the world, but our health is extremely important. You can't have a country developing in the right direction without the woman's health in the right track. Thank you again, and forgive me for interrupting. I would like now to welcome Her Royal Highness Princess Rima bint Bandar Al Saud, who's a friend and who has helped me tremendously. I share with you that I'm currently researching a book on Saudi women, and when I met Princess Rima, suddenly I had hundreds of girls who not only want to talk to me, but also would like to have that picture on the front cover of my book. So she's been extremely helpful. Princess Rima is not new to philanthropy and hard work. She's one of the pioneering women in Saudi Arabia. I think she comes from a long line of pioneering in her family. I know her aunties, her mother, amazing, really amazing woman who do everything, if you like, in that country. So also, she's the first ever woman who has become the vice president for Women's Affairs of the General Sports Authority. This is a new thing in Saudi Arabia, and Princess Rima was in Brazil, indeed, with the team. So I'm really looking forward to a wonderful conversation with the princess, and then later on I will invite Dr. Anna Lenge again to the stage. Hopefully we'll have time for a few questions from the audience. Thank you. Hi, Princess Rima. Yes. Princess Rima, tell me, what is Al-Zahra Society? I know this is how you became involved in a very wonderful thing, which we'll talk about now, which entered the Guinness Book of Records. So first tell me, please, about the Al-Zahra Society.
So the Sahara Breast Cancer Association, and represented by my colleagues here, is the first breast cancer-specific association, NGO, in Saudi Arabia. It was founded by a group of ladies who I'm indebted to, who started their career with an awareness committee, and there was 11 of them. And their tireless work led to a collaboration between the founder of Zahra, Dr. Saad, and my mother, to create the Sahara Breast Cancer Association, which is named after Dr. Saad. She is one of the most preeminent oncologists in the Middle East and started the first tissue bank for breast cancer storage and research in the Middle East. So we're very, very proud of her and her work.
And tell me the story of 10 KSA, which made it to the Guinness Book of Records. Tell us the story. It's a very interesting one.
You see the videos of the days leading up to 10 KSA. It took us 2 years to organize an event that was focused on holistic health. The mandate was to draw in as many women in Saudi Arabia and also to pull together as many government entities and NGOs to raise awareness on the mandate of holistic health. What we realized is the symptoms of breast cancer and the remedies for it and the community that is needed to support the individual is a similar community needed for any other disease. So it would be a shame for us to limit our efforts exclusively to breast cancer. So working obviously with the Sahara Breast Cancer Association, but also with the Ministry of Health, Ministry of Social Welfare, and other entities to make this event happen meant we had access to as many NGOs that related to emotional, mental, physical, and environmental health, but it also meant we had the momentum and drive to validate research. We composed 3 different researches on that day that will really impact the health system. And moreover, we were able to gather 500,000 riyals for the Breast Cancer Association itself. And the thing that makes me the most proud is over 13,000 women were in attendance. We broke the record with 8,264, I believe the statistic will come up. But the 13,000 women that were in attendance were 1,900 female volunteers and recruits from security to safety and the cleanliness teams and the food teams to help make this event happen. That's the largest gathering of women in Saudi Arabia, and it was an event organized by women, for women, supplied and serviced by women. So for that, I'm profoundly grateful and profoundly proud.
Yes, I am indeed very well aware of your mother's connection, Her Royal Highness Princess Haifa, and the Breast Cancer Society. But may I ask you, do you have any personal stories with cancer?
So the reason I joined the Sahara Association was because I lost a very dear friend of mine, and she is the namesake of my child, Sarah. And I found out of her having breast cancer about 2 weeks after I was asked if I would join the association, which, by the way, I had no intention of doing. I had no intention because I had just moved back home to Saudi and I had many things on my plate, and I thought, I'll write a check. And many people, I think, view charitable causes as writing a check and observing it from a distance and letting it ride its course. But when you're touched by it personally, you feel you must do something. And the thing is, I'm not a doctor, I'm not a nurse, I'm not in the medical field, and there's not much I could give to this cause except support. And what I hope that the people in the room who are not in the medical community can understand, whatever skill set you have to offer is valuable. And the skill set I have to offer is awareness and connecting the community. So I will use my resources and I will use my contacts and I'll use my voice to get the word out there, because that's my role, to open that door to allow for other people to give that message.
But I understand even in your new role, which is an amazing role in Saudi Arabia, you're managing to bring women's health into the fold. So maybe you can tell us a bit about that.
So the role I've been given is quite peculiar, because the actual title is Vice President for Women's Affairs, but the department I'm responsible for is sports development. Now, sports development in its widest form, what I'm being asked to do is to create the sports economy and develop the sports industry. When you look at that within sports, and its expanded term is health, well-being, and physical fitness, which are things that obviously are near and dear not only to my heart, but are imperative for a community mindset shift as relates to health and well-being, and that will support lessening of disease. It will support reducing the burden on the health industry. So almost by default, I have been placed in this position where I can now, on a national scale, impact the very thing that I would love to impact, which is stopping the flow of disease in our communities. And you're from the Middle East. You mentioned smoking, but it's not just smoking. It's obesity, it's diabetes, and so many diseases that we could help minimize if we were healthier. So I'm really absolutely profoundly honored to be in this role. And I've learned so much from my colleagues with the Breast Cancer Association, and to be able to take what I've learned from them and to realize there are so many other players in this field that can help impact, it's phenomenal. And within the role of the sports development and the sports economy, knowing that my role will also be to include women into this sector brings me infinite pleasure, because that is also how I started my career in retail and bringing women into the retail sector. So opening job opportunities into another sector that then has positive impact on health, it brings my life full circle.
Absolutely fascinating. Now, it is known that in Saudi Arabia you have amazing doctors, you have amazing medical facilities. However, as you said, we both come from the same area where women are shy to talk about reproductive medicine, or to even say, I have a lump in my breast, or even to be examined by a doctor. And sometimes it's the men as well. So what is the challenge for these things in Saudi Arabia, and how do you tackle them?
The challenge is making the dialogue mainstream. So a lot of people would ask us, what value did a ribbon have to, or this event have to, breaking the taboo in breast cancer? Well, it made you have to talk about it. It made you have to say, I agree or I disagree. And just bringing the words into the household and generating a conversation is step one towards awareness of communication. What we have to do, and the challenges and the stories I've heard from my colleagues range from the woman who's ashamed to lose her femininity, to the woman who's afraid of losing her husband and therefore her family, to the woman that actually is afraid to just know. And the fear of just knowing, I think, is a universal fear, but the fear of losing your family status is uniquely Middle Eastern, because in our region you do have multiple wives. So a woman will actually put herself through suffering until it is too late to not lose her attachment to her children, to not lose her place in the household. So the social taboos go farther than breast cancer, and it's something that as a community we must actually begin to educate ourselves. It goes back to another thing that's near and dear to my heart, which is financial independence for women. Because I believe if a woman is financially capable and independent, this fear is now removed so she can focus on her health. And financial independence is tied immediately to self-sufficiency, and health is immediately tied to self-sufficiency. So educating women on that trifecta of a platform is part of what I would like to do. When we talk about the taboos, what the work of the Breast Cancer Association does, and I point to the ladies because they actively go out, I don't. I've never seen this with my own eyes. I've heard the stories that they tell me. So if you have a chance to speak to them, they're sitting right here. They go out and they talk to women who daily face this fear, and they go out and speak to these women sometimes 2-3 times. And to have the women enter the healthcare system at stage 3 or 4 is heartbreaking when we realize it is not a medical inability or inaccess to healthcare, it really is the societal issues. So we have a huge tackle or battle ahead of us. And when I saw some of the statistics, it's a question I always ask. there are more cases of breast cancer being diagnosed in Saudi. Is that because we've been efficient and effective in removing that taboo and more women are speaking out? Or is it on the rise? I don't have the answer to that.
Do you think education has something to do with it? Because I remember the first time I went to Saudi Arabia 14 years ago and I did a supplement for Al Hayat newspaper. I remember that the ratio of graduates from university was 57%. Women are 57% of graduates. Today, I believe it's closer to 67%. So do you think education has played? Because I certainly have seen a huge difference in the last 14, 15 years with the empowerment of Saudi women. I think also economic independence has a role to play. But do you think as far as health issues as well, all these elements are indeed coming to play?
I think it does come into play, and I think it is evolving. The issue goes back to education on a surface versus family culture. If your family culture is to keep whatever you're going through quiet, it doesn't matter whether it's breast cancer, a child with Down syndrome, a husband with an injury. We are a very private community, a private society, and we're even private in our suffering. And this is one of my issues with healthcare. When we are so private in our suffering, some of us will leave to be treated out rather than in, which then immediately impacts the awareness of our healthcare system of these diseases. So if women with breast cancer leave and are now not logged into the system, when the Ministry of Health is doing their databases and assessing budgeting, if the numbers aren't there to prove the value of that financing, then the numbers aren't there, no matter how loud we scream, no matter how much we flag it. So it is, though, very difficult when you look at a patient and say, you must be treated at home, because it's every human being's right who has the access to healthcare to go find the best solution for them where it exists in the world. So it's this very awkward, I guess, step forward, step back that we have. But the Sahara Breast Cancer Association has been very well supported by the Ministry of Health, and I believe they view us as an active partner. So we've been very fortunate in our relationship with the Ministry of Health.
But I mean, your work now in the sports department, sorry, my journalist instincts are kicking here, but I think as a woman, do you find it difficult to push the agenda of health? Or is it easier because of your position? Or how do you tackle all this? And how do you indeed use your position to push your agenda?
So we have just had a vision for the nation announced a few months ago, and it's the 2030 vision. And one of the key pillars is sports for all, but so is a healthy and vibrant community. So the fact that I have been, my appointment was through royal decree, that means somebody up there believes this position must be filled, which also means somebody up there feels we must act. And I feel very mobilized by that and supported by it. I have to date not yet have anyone told me to stop what I'm doing. And the plans that I put forward, I'm very mindful and conscious of the cultural context. I did grow up in the States. I did not grow up in Saudi. And my first few years were really interesting in learning what are cultural boundaries. But this isn't a one-man show. This isn't my personal business, so it's not my personal opinion. The work that we're doing is based on statistics and research. It's based on community engagement, because if you do not have the buy-in of the community, it does not matter how phenomenal your program is, nobody will use it. It doesn't matter how beautiful your facility is, nobody will come. So one of the core foundations of the work that we're going to be doing is the socio-cultural behavioral management campaign. And what we would like to do with that is transform this nation from today of one that is not physically active by choice to one where physical activity is a matter of fact. And to do that, we become then the support for all of the programs that are the physical action and physically active programs of the General Sports Authority.
So I take it then you have already programs that are lined up to be implemented.
Yes.
I think it's worth saying here that one of the very interesting interviews I've done was with a group of women doctor researchers in cancer at the King Faisal Hospital, I remember years back, and now there is more and more. It was also very interesting that when I went to the hospital, Defense Hospital, that I met some men who said they'd rather be seen seen by women rather than men, because the women are kinder and they give them more time. So it's interesting, while we have all this image about Saudi Arabia being male-dominated, which, to be honest, it is in many ways, still I think women are really making breakthroughs in every direction. But let's go back to your work. I've been going around the kingdom in various areas. Do you think that the care and the awareness of cancer specifically in the remote areas of the kingdom are the same like they are in Jeddah or Riyadh?
No, I don't believe so. And I don't believe so only because it would actually be impossible. Our organization cannot be everywhere at all times in all places. We've branched out to multiple locations, and everywhere we've gone to, you can see the immediate change. And our conversation is not exclusively breast cancer, it's women's health included in the breast cancer. And we have phenomenal programs that are, I would say, health mentoring or engagement. And Haifa, one of the young ladies here with us, actually goes out and does the mental health elements of the work that must be done, and she leads workshops and she talks to people. The evolution that we have to make in our healthcare is not exclusively in the physical healthcare, it's the mental healthcare also.
Sure.
And the mental health is very much still a taboo, but it is so immediately must be dealt with in parallel to the physical aspects, because it affects the child, it affects the husband, it affects the woman herself. We are also a faith-based nation. And when you have a faith-based nation, your first reference is to God, which is phenomenal and sensational, and it must be, if that's your belief system. But God would also say, I believe I've created doctors and medicine, and go and benefit from that.
Yes,
so
absolutely.
reach out. So we have a lot of issues like that also, but our work is forever going.
Oh, yes, of course. Is it fair to say that actually breast cancer in women is the #1 killer in the kingdom? And is awareness the main problem?
I would say it's one of the top 3.
One of the top 3.
And I would say lifestyle would be one of the major causes.
Which is obesity and cigarettes, because Saudi Arabia is known for very high levels of obesity and diabetes.
We are today at a national healthcare crisis. We are 1 to 2 years away from hitting the wall across the board in health crises, from diabetes and obesity, which is what makes my job so much more difficult, because while I am starting with greenfield and zero to say, I have the ability today to create anything. I have the ability to start anything and measure the impact of it today, immediately. But what I am starting with is less than 0 on a health system, with less than 0 on an economic system, at less than 0 with an awareness system. And I'll give a very brief example of the challenges that we're facing. My organization has created another department that is a sister department to mine called Mass Participation, and its goal is to get the community mobile and physically active, and it targets age 0 to 99. It is not elite sports, and it is not Olympic level. It's your day-to-day clubs and hobbies. They have identified 10 clubs and hobbies that they would like to scale across the country to engage young people in, and it's phenomenal. And I'll give you one example, is the bicycle riding club. They have instituted and supported a bicycle riding club in Riyadh, one in Khobar and one in Jeddah.
And for girls as well?
Girls and boys, it's gender neutral. Okay. However, it's unscalable, because besides Toys R Us, there is only one store in the capital city that sells bicycles. So there's no industry around the sport that you would like to be the hobby. If there's no industry, not only do you not have an economy, you cannot actually scale it. So my job is to look at these 10 initiatives that they've got for this year and to grow the economy and the industry around it to allow for the hobby to scale. Once we do that, we're hitting on multiple layers. We're creating an active and dynamic community, yes, from health and physical activity, but we're now also creating jobs. We're now creating opportunity, and we're creating businesses. And then with that, we're expanding those businesses to be not just physical businesses of I have a store and I sell bicycles. There's the individual that has to repair the bicycle. There's the doctor that's going to be fixing everybody's knees when they fall off the bicycle. It keeps going. There's the magazine called Bicycle that has now photojournalists and journalists on physical activity. So there's so much that can mushroom out of a small hobby club. And that immediately and directly impacts everybody's health, because now we can move. And it's very exciting.
Yes, absolutely. It's very exciting, but it's a tremendous job. And do you find that the other ministries, for example, like the health ministry, is able to cope with all what you are planning to do? And how are they indeed reacting to all that?
Okay. So everybody I've met with has been predominantly proactive with us. Whether they buy into it or not, I don't know, but we are all being held to delivering on the mission. And the mission and the vision is 2030, to have this vibrant, dynamic, rich society. And rich, I don't mean financial. That's somebody else's dialogue. We mean as a vibrant community. In order to do that, every single government entity has been given a series of KPIs, and one of the biggest KPIs is integration, it is deregulation. Another one which I'm very, very happy about is the integration of women. There is job creation and business development. So across the board, whether these entities buy into it or not, we're all accountable, and we've all been given this one vision. And I have found everybody to be profoundly proactive.
How many hours a day do you work?
I think 26.
I thought it must be. Something else, I mean, Saudi Arabia is of course known for being a very wealthy family, country, not family, but country. Is there a problem with financing people? There is no medical poverty in your country. I'm assuming that everybody is able to get the health care free, able to be hospitalized, treated for cancer, etc.
Healthcare for a citizen is free, and then there's specialized healthcare, obviously, and then there are the private hospitals. I wouldn't say it's an issue of the finances, but it's an issue of the correct use of resources, and it's an issue of coming into the medical system at the right time or not the right time, or going in to the right doorway. We are very known for going to the emergency room for everything, which means when there's an emergency, there's no room for those people. We're known for treating ourselves too late, which is also not helpful. So how do we create the healthy flow into the medical system is something that I think the Ministry of Health is working on.
Would you say, because in my research I found that most of the problems in Saudi Arabia are not related to Islam, they're not related to religion, they're most related to adat wa taqalid, you know, like it's what the society wants us to do, it's what the neighbor is looking at us for. So my question is, are these diseases also affected by this? That I shouldn't go and see a doctor because my neighbor will not like what I'm doing? Or is this now opening up as well?
I would say it's opening up. And it's not so much, when we were talking about culture versus religion, yes, it's faith-based, but the culture of a family, I would say, is more the factor that's at play than the culture of the community. Because even though we are major cities, we're actually a tribal community in the center of the community, of the country, and we are a globalized community on the banks of the country. And the reason for that is we have the holy site of Mecca and Medina, so many, many pilgrims over thousands of years, even pre-Islam, were coming through the region, and they bring their own cultures and their own ethnic sensibilities to the region. In the center, it's a nomadic group. We are the Bedouins. Yes. And so the culture of each area is different. The culture of each tribe within the area is different. The culture in Jeddah, if you come from a Southeast Asian area, will be very different than if you came from a European area. And it's not a matter of enlightenment or not, it's just family culture. And so I think that has a lot more to play. And then our role with the General Sports Authority is to create a unifying voice. And that unifying voice will be physical activity is good for all. These are multiple ways you can participate. When you participate, we can show you how you will be healthier. And that's very different than saying you must exercise or you must jog for 30 minutes a day, because I will tell you there is nothing anybody in this room could do to make me jog or run unless you were chasing me, and even then I'll give up. So I apply my mindset to everybody else. If you couldn't force me, what could you do to convince me to include physical activity in my life? And sometimes I see smoking kills. I don't know how many people have stopped smoking because they saw that smoking kills. You know it, you rationalize it, and you ignore it. However, if with exercise, if I could just bring in multiple ways to get the community to engage as a part of their day, it will be so much easier than to force them today in a vacuum to have to exercise 30 minutes a day or 20 minutes a day. So we need to work on not just the mindset, but then to create the opportunity.
Absolutely. I mean, I don't know how many of you here know that Saudi Arabia is the size of Europe. It's a huge country, very, very, I must say, very well linked with good roads. But is your authority trying to reach to the remote areas? Because this is, I think, a very important aspect.
It's our mandate. We have 23 regional offices, some larger than others, even though it's 13 states. So our biggest failing to date, two big failings. Number one, the women's cause has never been addressed, ever, 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 ever. And not only has it not been addressed, it's been obstructed, willfully and willingly. And that immediately changed not only with my appointment, but with the new mindset of the country. The second failure we have, even for young men, the industry that has been promoted is football, to the expense of every other industry, or soccer if you're from other parts of the world. So if you ask a young boy, what would you like to be? His only option is a football player in sport. And even though other sports are mildly represented, they're not glamorized, they're not exciting, they don't have the facilities. So our role is really to create a mandate of sports for all, which means opening up the door to hobbies and clubs and taking away the competitive nature and making it a bit more egalitarian. Everybody can come and play. It's play for all. Because the day you take competition out, even the worst player wants to play.
Absolutely. I think you will all join me in thanking Princess Reema. This has been a fascinating dialogue, and thank you very much. I think we should thank the Princess for her very direct, honest, and sincere answers. I really enjoyed that. Thank you so much, Your Royal Highness. Yes, please. I would like to invite Dr. Lange again to the stage, please. I think we might have probably 10 minutes of questioning. And when you raise your hand, could you kindly say who you are, where you come from, so that we realize? And please make your questions as short as possible to be able to get more questions. And if you indeed have a comment, could you also make it short and effective? Thank you very much. I'm trying to look and see the hands. There is a hand here in the front. Please, sir, do we have microphones anywhere? Let me give you this microphone, sir.
I am Lalit Gandhi from India. We are operating one mission, cancer control. We are working in awareness, prevention, and early detection screening. We are running 2 mobile cancer detection centers throughout the India. As you all know, India is the huge country and huge population. In last 2 years, we have screened almost 36,000 women for breast cancer and pap smear.
Wow.
We are feeling pap smear, the cervical cancer test is very expensive in India. And the treatment is also very expensive. We have detected almost 3.5% women affected with cancer, either or breast cancer or cervical cancer. We have recommended them with their regional government hospitals. Can you guide us to reduce the cost for this cervical cancer test in India, and the technical support or technological guidance to improve the effective test for breast cancer and cervical cancer test?
Thank you very much. I think this is quite a specialized, difficult question. Would you like to address it, Dr. Lange?
Sure, I will try to address it. I mean, cost is definitely a big barrier, and that's why finding innovative ways, establishing partnerships with the private industry, and we had some sessions on the role of pharmaceutical companies and other technology companies, is quite critical to make prices affordable. We have some other areas of health we can learn from, and there was a session during which the example of HIV drugs was given as such an important drop in prices of the drugs from $15,000 a year to $100,000, thanks to a very, very active advocacy community and those private and public partnerships. So I think that for breast cancer and cervical cancer, we should adopt similar strategies. It's a big issue. Thank you.
Any other questions? So, oh, yes, another gentleman from India.
Yes.
Yes, please.
I'm Dr. Grover. I'm
Hello,
professor
doctor.
at Delhi State Cancer Institute. I just want to ask from Dr. Lange, I agree with our observations and recommendations, gender inequality, it's fine. I think we'll all shall agree with that. But what she mentioned was women with gestational diabetes, postpartum psychosis, or preeclampsia are more likely to have chronic disease later in their life. I think that's accepted again. But does it mean that a woman who has not conceived is likely to remain healthier? But this also means that a nulliparous woman is at high risk of developing breast cancer and ovarian cancer. So how do you strike a balance? And despite these gender inequalities, life expectancy of a woman is marginally higher than compared to males. So a lot of disparities are there. Could you please explain? And I also like to add, to share a very happy thing, from Delhi in India, we are going to start HPV vaccination and anti-tobacco program for the first time as a public health program from 7th November, which we observe as National Cancer Awareness Day, which coincides with our birthday of Marie Curie.
Thank you, sir.
This is a happy
Thank you.
question we want to start, and I want some clarification from Dr. Lange, please. Thank you.
Dr. Lange. Sorry, Dr. Lange didn't understand the first question. Could you kindly just briefly?
Yes.
Very
Women
briefly.
with gestational diabetes and postpartum psychosis and preeclampsia, they're likely to have higher chronic disease later on.
Yeah.
Does it mean that woman who has not conceived is likely to be healthier in life?
So women who don't have children, are they likely to be healthier later on in life?
And a nulliparous woman is more likely to have risk of breast and ovarian cancer.
Yeah, that's a very interesting point. I don't think there is any evidence that shows that women who didn't have children are healthier. I mean, there is evidence about some specific things. For instance, protective factors for breast cancer, like number of pregnancies and length of breastfeeding. But overall, I don't think that's a statement we are ready to make. That women who didn't have children are healthier. You are right, women's life expectancy is higher everywhere. So apparently, we women are genetically better prepared to live longer lives. In spite of all the challenges we face. And congratulations on the wonderful news about
Delhi.
That special day.
Yeah. Thank you. Any more questions? I'm happy to take one more question. I see people are getting tired and hungry, so I'll, Faddali, please. Yes, you need a microphone. I think. Thank you, Dr. Lange.
My name is Sonia Zavzavajan. I'm a member of the Lebanese Cancer Society and a patient advocate for breast cancer patients. I thank very much the presentations you made, and I would like to ask Her Highness about the numbers approximately of young women, because in Lebanon we have the highest number of the youngest ladies in the population. And since we started with the Ministry of Health, the program of screening and exercise and all the nutrition...
Sorry, you are talking about breast cancer, highest number. Thank you.
Yes. The numbers have decreased in ladies' health. They are better. We have less death, and we have younger and all women accepting to go to the mammograms and to go and see the doctors. We have the same culture, we have the same things going through, because people, they didn't want to go to the doctor, and we have the taboo, they don't want to talk about it. So when I used to give lectures in far villages, in the towns, and people started asking each other that they should go for treatment and for screening. So I think you have approximately the same thing. Are you facing younger people having breast cancer?
Thank you very much for my fellow Lebanese. Thank you. Please.
There's a shocking rate of cancer, not just breast cancer, in younger people, and there's circumstantial evidence, and nobody can make it concrete, relating it to the Gulf War. Because if you look at the epicenter of where it is, not just breast cancer, brain tumors, miscarriages, infant cancers, emanating and then disseminating from the core of the north of the country. But it's circumstantial, and I think until the international community wants to address that, we're never going to have real numbers, it opens up too many conversations that I think are uncomfortable for the world. But we do see, unfortunately, younger people with cancer, but we do see an awareness with younger people because of social media, because of social inclusiveness. We are more comfortable with ourselves and our bodies, and we're more comfortable talking about it.
I'm presuming, Your Royal Highness and Dr. Lange, that social media is also helping with awareness. I wonder if you do use it to spread awareness about the diseases. And social media has two aspects. One is really bad, and one is very good. Please.
Our campaign was single-handedly and exclusively messaged through social media: Twitter, Instagram, Facebook, WhatsApp. Unfortunately, the BlackBerry Messenger no longer exists with us, but that is how we communicated with everyone, and that's how we connected with everyone. So we really are, if anyone would ever like a case study on social media's effect and impact on community and communing people, our event is that, and we'd be happy to share with you all of our statistics and the methodology.
I think you should know that Saudi Arabia is one of the usage of social media is one of the highest in the whole world, I think. So it's very interesting. Dr. Lange, would you like a comment?
Sure, very briefly. Social media are extensively used as platforms to disseminate messages in the global health community, and also mobile phones. I mean, mobile phones are making such a huge difference because people who didn't have access to line phones now have access to cell phones. And there are many programs that use mobile phones to educate, to guide providers, to give better care to their patients using algorithms. So these new technologies are quite amazing. They need to be evaluated, though, and they need to be scaled up in some places, but they are providing a wonderful tool.
Please join me in thanking both Princess Rima and Dr. Lange.